Yeah, thanks very much, Chairwoman Clifton, for the invitation to come and speak. It's always a pleasure to be in London. I am the director of Leipzig Heart Center for almost 2 years now, and we have a unique position there in that we did the first successful transapical TAVI back in 2005 worldwide. And since then, we have gathered a very large experience with transcatheter valve techniques, and therefore I feel happy to give this talk, although I have to say I do not personally do transcatheter techniques, but as the director of the program, I'm a very strong supporter and also help to guide and form the program's future directions. These are my disclosures, although I do not receive the money directly that go to my hospital. This slide you've seen many times. 57% now of isolated aortic valve procedures in Germany are done with a transcatheter technique. The trend you saw already from Miss Evans in the UK, and I can predict it's going to continue here in the UK. And in the US, they're also over 50% now. Part of the reason why in Germany it went up so quickly was because of financial incentives, that the hospital makes a lot more money with TAVI than they do isolated aortic valve surgery. Interestingly enough, we've reached a point now in Germany, because the insurance companies have dialed back so drastically the reimbursement, that now surgery is just as financially lucrative as TAVI. So now the next couple of years are going to be very interesting to see what happens to that curve in Germany. This is the number of heart operations in total, including TAVI, and you can see there's been a slight decline over the last couple of years, mostly because of the drastic decline in coronary bypass surgery. So this is the number of operations without TAVI, so this is with cardiopulmonary bypass, went from 91,000 in 2007 down to 79,000 in 2016. And as I said, this is predominantly driven by coronary bypass surgery. Last year alone, in 2018, we did 3,000 less coronary bypass operations in Germany than in 2017. This here, we're all talking about valve therapy, and we're getting our knickers in a knot about transcatheter valve therapy. This goes against every bit of evidence there is out there. This is where we should be focusing our energy. Anyways, we do have a large TAVI experience. At Leipzig, we do over 800 a year. That's partly to do with the fact that we belong to a company that owns 120 hospitals in Germany, and we get sent a lot of the patients specifically for TAVI. But it also has to do with the fact that the results are getting better and better and better, and we're getting more and more efficient, and these newer generation devices are improved. Also, a big part of this success story from my point of view is the fact that from the first day, Professor Moore, my predecessor, really strongly believed in this heart team concept. This was something that he developed together with Patrick Sorois for the Syntax trial for coronary disease. People forgot that the heart team actually came from coronary surgery. And then they said, hey, this really should be applied in TAVI as well. And I can't stress this point enough. This has to be a joint cooperation. We learn from the cardiologists learn from us, and the patient benefits at the end of the day. So these are the two leaders on the left of our structural heart department, which is a sub-department in our hospital, led equally by a surgeon on the left, David Holzai, and a cardiologist on the right, Mohammed Abdul Wahab. And this is just all in a day's work. This is from 2 weeks ago that I just picked off of our computer program, where we show the different operations that we did that day. Here you see we did 8 TAVI cases in 2 hybrid ORs, and we were done at 3:30 p.m. So this technology is moving very, very quickly and is becoming very efficient. As I said, in the United States, mirroring our experience in Germany, they are now doing more TAVI procedures than they are aortic valve surgery, and the number of aortic valve operations peaked in 2013 and has been slowly going down since then. Access, the transapical technique, has basically disappeared at our center as well, which was previously a big proponent of transapical, predominantly because of Tommy Walter. We also perform transapical in about 3% of our patients now, with the vast majority undergoing TAVR. So this is from the STS ACC TVT registry database from the US. And there's been less cardiopulmonary bypass, there's been less conversion to open heart surgery, there's been less procedures aborted over time, all of these down to less than 1% in 2016. There's been less major bleeds, there's been less major vascular complications, and there's been decreasing ICD and cardiac arrest, but atrial fibrillation rates have plateaued but are still quite a bit lower than they are for open surgery. And of course, the mortality rate has gone down and down, below 3% in 2016, but I can tell you at our center, for example, our mortality rate is 1.5%. And the costs have also gone down as the patients are getting sent home from the hospital earlier, as you're able to start eliminating some of the other costs, including general anesthesia. These are becoming more cost-effective procedures as well. Right now, there are ongoing low-risk TAVI versus surgery trials around the world. 2 of them will be presented next Saturday morning in New Orleans at the ACC, and those are from Medtronic and Edwards sponsored. What I would like to point out is that the UK TAVI one and the Dedicate one in Germany are not industry sponsored. I think that does play a role, and therefore I would say try not to focus too much on the results coming out next weekend, and let's wait a little bit longer for, let's say, a little more unbiased view of the picture. But the fact is that both of these trials next week are going to be published simultaneously in the New England Journal of Medicine. I don't know the data yet. I will on Friday. I'm a panelist for these studies, but I'm assuming that they're going to be non-inferior and that this is going to result in another wave of patients that are being sent for TAVI. So what is the future of patients with aortic stenosis? Well, as I said, those low-risk trials are already underway. There's going to be modification of the guidelines based on those trials. And I think we're going to be making a paradigm shift from when is TAVI appropriate to when is TAVI not appropriate. That's just the honest-to-God truth as a cardiac surgeon. So what are we going to do about this as cardiac surgeons? We need to get involved. We need to be making sure when we look at this innovation curve, as you all know, that we're not being labeled as laggards in the future where we say, oh, everybody should be getting a conventional aortic valve replacement. There are patients that are benefiting a lot from TAVI, but we have to use our experience and our knowledge to also put the brakes on sometimes of our more enthusiastic colleagues and say, hey, this is not appropriate use of this technology in this patient group. I'll switch now to the mitral valve landscape. This is an old slide, as you see, 2015. I can't even show you the one for 2018 because the print is too small for all of the companies that are currently out there and having tested their devices in man. A mitral regurgitation for primary and secondary. Of course, you have repair and replacement. There are the surgical options, which we all well know, but there are many more percutaneous options that are currently being investigated. And it's just an interesting story because the mitral valve has turned out, as you know, to be a much more challenging environment than the aortic valve for these transcatheter techniques, although we originally thought it would be the other way around, for the reasons that you see listed here. A lot of them can be taken into account with better preoperative imaging, but not all of them. The one thing where I think these techniques are going to have still a problem with is they all have a large footprint in the atrium. Blood flow velocity is low there. What are we going to be doing about thrombus and thromboembolism risk for these devices? In 2015, there was acquisition. Edwards acquired cardiac. Abbott acquired Tendyne, Medtronic acquired 12. These were all transcatheter mitral valve replacements. And I know Thomas is going to be talking about this later, but and Heartware acquired Valtech, which was then acquired by Edwards. $2 billion was spent in a very short period in 2015, and there was 30 patients worldwide that had received these devices. That's quite a large investment. But is that investment worth it? Well, the transcatheter mitral valve edge-to-edge technique, the MitraClip, is also, I think, the focus of the next speaker. Therefore, I won't say too much about it, but this has come under a lot of criticism from the cardiac surgery community. We look at the Everest 2 trial and we say, hey, look, the recurrent MR rates was unacceptably high in these patients. These patients required much more surgery, redo surgery in the future compared to those that were randomized to isolated mitral valve replacement surgery. But these were the 5-year results which were published back in 2015. If you look at these trials, and you don't need to look at the data here, this is just a summary of the more recent studies. On the left is Everest 2, but then there's Access EU registry, there's a Sentinel pilot registry, there's the TRAMI registry, all with hundreds of patients. And the success rate has gone from 77% in Everest 2 all the way up to 97%, and the reoperation rate has gone from 21% down to about 1 to 2%. So these techniques are getting better and better and better. This is what you call, what is the word for it? Progress. This is progress. Progress is not fair to everybody. It's not fair to the cardiac surgeon who used to do a lot of isolated aortic valve replacements, but it is fair to the general group of people. It's fair. Progress is in the interest of society, although certain elements of society will be hurt by progress. MitraClip procedures in Europe have rapidly exploded, and in Germany in particular, they passed the number of mitral valve operations in 2016. You can argue whether or not that's always being done appropriately. TAVI in Germany still needs to, it's supposed to be a heart team where you have a surgeon and a cardiologist on the table, which is the case for 100% of our cases, but it's certainly not the case in all centers. The surgeon is sort of pro forma there. But for MitraClip in Germany, you just need a surgeon just to sign a piece of paper. You do not need to, it does not need to be done in a center that even has cardiac surgery on site. And I think that has partly led to that fact that there has been such an explosion of MitraClips in Germany. So should we all just simply give up right now and tell medical students don't go into cardiac surgery, you should go into cardiology? I would say definitely no. The answer is no. We probably don't need as many cardiac surgeons in the future as we do right now, but we're still going to need cardiac surgeons, and I think we play an extremely important role for ensuring the optimum outcomes for our patients that have complex situations, which were alluded to already before, but also even for those transcatheter techniques. We need to join in the transcatheter revolution and make sure that the cardiologists are benefiting from our knowledge and vice versa, and at the end that the patient particularly benefits. So do we need to have a TAVI fellowship from people that came out of cardiology and cardiac surgery? I think that's not a bad idea. I don't think you're going to ever get rid of the difference between cardiac surgery and cardiology. The world is getting more and more and more specialized. We're not narrowing down into a smaller number of groups. I think that's a pipe dream to think that we're going to get rid of the differentiation between those two. But I would encourage young cardiac surgeons nowadays to try to get experience with these transcatheter wire skills. Problem is that sometimes it's hard to get access to them. You need to spend time on interventional cardiology, although I do say, and this is the honest to God truth, they are easier to learn than the complex operations that we do. There are special courses, example for SCTS, where you can learn wire skills, which I would certainly send my young people to. And these wire skills can also be useful in other situations. We're doing more and more minimal invasive surgery, especially mitral valve surgery, where these wire techniques are quite helpful. We quite often put in ECMO on awake patients now using percutaneous closure techniques rather than cutting down on the groin. There's all sorts of interesting applications of these techniques that we can implement in surgery. In addition, more of a focus on the imaging techniques, especially fluoroscopy and echocardiography, helps us as well as surgeons to try to understand more about what we're doing in the operating room. And certainly our anatomy understanding, which is more than what most cardiologists have, is beneficial from their point of view. However, there's difficulties with political environment. The heart team, as I said, originally came from the Syntax trial, and the initial thinking in TAVI was that you needed a surgeon because of the large sheath diameters or the high complication rates. I remember very well in 2006 and 2007, we would get a phone call, or I would get a phone call back then, probably every second day, that there was a complication up in the hybrid room and have to send somebody up there and try to manage or at least find out what's going on. We'll go weeks now, weeks of doing 6 to 8 TAVIs in one day. Nothing. So the idea, though, has become increasingly being used, I think, as a catchphrase and not being used in the reality in a lot of centers. I think it's very important that the surgeon is actively involved and not just simply getting the coffee. One way to guarantee this is to make sure that you have a common budget. Take money out of the equation so that the cardiologist and the cardiac surgeon are not fighting over who gets to submit the billing. I think this is an absolute key to getting good cooperation between the two groups. This is the Valtech technique. I will just show this quickly. You all know this. I'll skip by this video. You all know how it works. Transcatheter mitral annuloplasty device. The results for functional MR, good, not great, but this is early experience with this technique. If you looked at our early transapical experience, you'd say, you guys are crazy. You should stop the program immediately. But look what it's become. Now, here's the NeoChord, which is also early, an immature technology. The Edwards Harpoon, the Cord Art, which I don't even have a picture of. These are all immature technologies, but they're rapidly improving. The NeoChord technique, as you know, we go through the apex of the left ventricle on a beating heart through a mini thoracotomy. Then under transesophageal echocardiographic guidance, you grasp that portion of the leaflet that is prolapsing. You confirm that you've got the leaflet by the lights on the outside of the patient that reflect the color between the two jaws of the device. So when the jaws are open in the ventricle and there's blood flowing between the two jaws, you see red. Once you've got the leaflet, you see white. And then once you've got a good grasp of the prolapsing segment of the leaflet, you fire a needle which grasps a Gore-Tex suture, which then you can exteriorize out of the left apex of the heart. And then there's a simple hitch knot that's done on this Gore-Tex suture, and with this hitch knot you can slide the knot up to the leaflet, just simply pass the free ends of the suture through the loop portion, pull, and then that slides up onto the leaflet, and then you can adjust the tension on that prolapsing segment under echocardiographic guidance until the prolapse has resolved. So this is just one simple case here. Advancing through the apex of the left ventricle, you see the P2 prolapse with flail. Once we get it across the mitral valve, which we're just about to cross right now, there it goes. Now we're in the left atrium. We open the jaws. Sorry about the distortion here. We open the jaws, and this is the way that it looks on the outside of the patient's body. It's you just release, that opens the jaws. Sorry, you close it to open the jaws, and then you release to close the jaws. And then once we see that we've got a good grasp of the prolapsing segment, we go ahead and fire the needle, pull the suture out through the apex, and then under echocardiographic control, pull down on that cord until you get the desired result. This was one that we implanted back in 2010, and this patient is out to 2016 now with still an excellent result. Not every patient is like this. There was lots of recurrent MRs, but we're learning more and more about the technique, especially from Padua's experience. Here, data from Andrea Colli showing that if you pick the right pathology, the isolated P2 prolapse, you can have very good long-term results. And we are going to be combining these procedures in the future. They've already been done, several of these in Mainz. This is a courtesy of Andreas Colli and Stefan von Badeleben. So they're putting in the Valtech device. The last screw is going in on the transcatheter annuloplasty. Now they go ahead and adjust the NeoChord under echocardiographic guidance, and then fix the sutures onto the apex of the left ventricle. You actually want to see that the leaflet is a little bit over-adjusted so that you get a little bit, even a bit of a reverse MR going in the other direction, because that will, in the next couple of days, settle out, and you'll end up with a very good result. And this is currently undergoing FDA approval study. And then last slide, I just want to show, these are the cardiologist and the surgeon for our transcatheter mitral valve team. As you can see, both young people. And I think somebody said it the best way to predict the future is to create it. That was Abraham Lincoln. So in summary, conventional cardiac surgery is being performed less often, and this trend is definitely going to continue. It will, however, remain the procedure of choice for certain pathologies and certain patients. Simply fighting with cardiologists in our own isolated silos is not going to lead anywhere. We know that story already from the multi-vessel coronary disease patients. And combining our expertise with our cardiology colleagues is a must. And the heart team should be actually lived and not just said. Thank you very much.